Good morning, good evening, good afternoon, depending where you are in the world, and thank you for joining this webinar. My name is Michael Moore. I'm a past president of the World Federation of Public Health Associations, and I currently chair a global task force on immunisation. More importantly, I'm coming to you from Australia, and specifically from the land of the Ngunnawal people, and I pay my respects to their elders past and present, and I extend that respect to Indigenous people all over the world, recognising the disadvantage they have suffered at a particularly important time in Australia, where I like to encourage people to vote yes to give the Aboriginal people and Torres Strait Islanders in Australia a recognition in our constitution and a greater say. But today, we're talking about allocating sustainable funding for resilient health systems and asking, is it a distant dream? We know that the lack of alignment between economic and healthcare worlds has resulted in inadequate strategy for sustainable healthcare investments. And numerous decisions that affect health are made outside the health budgets and also, of course, take into account areas such as land planning, transport, environment, and so on. And these will be elaborated on by our three speakers. And I'm going to introduce Professor Vivienne Lind, Professor Michael Baker, and Eduardo Pisani. But to start off with, I am going to introduce Professor Vivienne Lind, who's the Executive Associate Dean and Professor of Public Practice at LKS Faculty of Medicine at the University of Hong Kong. Vivienne has 40 years experience in public health with a variety of leading roles in policy and program development, health services planning, research, and teaching and senior administration in complex organisations. She was previously Director of Health Systems at the Western Pacific Regional Office of the World Health Organization and Chair of Public Health at La Trobe University in Melbourne before serving in WHO. And that's where I first met Vivienne and where I learned to admire her work. She's consulted widely and with a wide range of organisations. She earned a Bachelor of Arts from Yale, a Master's and PhD from UC Berkeley. My pleasure to introduce Professor Vivienne Lind.
Thank you so much, Michael. It's my great pleasure to join this esteemed panel and to be able to open the conversation. We often say prevention is better than cure, but if it's really better, then why is it we never seem to have enough money? And how might it be financed? And I think this issue is really all the more important now, taking on, I think, some degree of urgency in this post-COVID environment. When back in 2020, we talked about how we can build forward better. And now seems so many people are just desperately to go back to life as it were. And we know that is not the way to prepare for the future. So the key policy questions, I think that's certainly been important in my career in various contexts and conversations, is can we get a minimum or an ideal level of investment for prevention? And how do we finance it sustainably? The answers are unfortunately not so straightforward, but I want to start out by talking about how do we know what's actually spent, and then think about how should we spend it, and then how do we enlarge the pie. So I first started working on some of these issues probably about 30 years ago when I was the executive officer for the Australian National Public Health Partnership. But a more recent foray into the area was when I was Director of Health Systems. And, you know, we kind of had this dream. We thought what we need to do with 37 countries in area is to kind of really advocate for some minimum standard of investment. So, of course, the starting point is always the data. What is the minimum? Well, what do we actually spend now? So we undertook a study looking at total health expenditure. And total health expenditure is all public, all private, all out of pocket. And so we used national health accounts in order to do comparable definitions, and I will explain that in a minute. But essentially what we found was a huge variability across the countries. We actually never published this study because there was so much more work that needed to be done with the data. But roughly what we could see is that Australia and New Zealand, if you take two countries that in many ways have similar approaches to government, similar cultures and values, New Zealand spent twice as much as Australia did. And then you look at Korea and Japan, and there's two countries that are also, in a sense, somewhat similar in the way the health system works and culture, and they were comparable, and both were much higher than Australia and New Zealand. So this obviously raises that question of, what goes into all this? Now, the OECD, which I will also explain their system, in 2017 did an expenditure study using their system of health accounts. And what they found was that preventive care averaged about 8% in terms of total health expenditure across the Asia Pacific region. Australia, sort of bottom of the class at 2%. I can say that as an Australian. And Fiji was the top at about 20%. So this, of course, just makes it a little bit difficult to say, well, how much should you really spend? Now, just so that you're clear on these definitions, and there are these two systems, under the WHO's National Health Account system, there's a category of preventive and public health services. So by going to National Health Accounts data, you are getting comparable data from across countries. And if you just look at those dot points of HC 6.1, 2, 3, 4, 5, et cetera, those are the categories of expenditure. And the data is collected in that way. But if you go to the OECD and look at how they report current health expenditure, then this is their total taxonomy. But again, if you look at HC.6, they call it preventive care. And this preventive care actually looks quite different from the WHO. So if you're going to compare expenditure data, you need to decide whether you're going to do the OECD data, which is, of course, OECD countries plus any other additional studies they do, or you're going to go with the WHO's National Health Accounts in order to get that comparability. And one of the challenges in both systems is actually defining the boundaries. So you always just have to check the definitions. But in the 2017 study, I won't go through this in detail, but if you just focus on that light area, which is called preventive care, you'll see Fiji comes out very well on top. And then to the right is OECD, and that kind of gives you the average. And you can see this huge variation across the different countries. This is total health expenditure. If you only focus on government and the compulsory insurance schemes, then there are certain things that drop out more. And you can see that the preventive care comes up a little bit more strongly because a lot of that is government expenditure. And the personal aspect of preventive services is often done through insurance schemes. But nonetheless, it's still highly variable and not very significant. Now, in the most recent National Health Accounts report from the WHO, they did look at spending during COVID. This is an extract from that report, and I won't go into it other than to flag a few things. The most significant is the yellow highlighted, which is that per capita spending on preventive care rose 32% on average across countries. So you can see that the countries were obviously responding to the pandemic, but here is then, therefore, the constant dilemma for public health in every country, which is when there's a crisis, when there's an outbreak, that's when the money goes up. And then quite often the money goes down after that. And, you know, there's a couple of interesting things that also happened. During 2020, the out-of-pocket spending actually fell in that first year. And that's because a lot of people did not use health services, either because they chose not to, or because some governments actually stopped some services from being offered. I think the other quite interesting thing is that when you actually look at the expenditure on COVID, more than 40% was actually allocated treatment. And you'd expect that, of course, given the fact that people were hospitalized. In 2021, you saw more funding being allocated to vaccination, testing, and contact tracing. So this is where it's highly variable. And what we also know in many low and middle income countries is that they do not necessarily have a public financial management system where there is a surge capacity funding. So quite often in the lower and middle income countries, to actually get the funds to respond is not that easy. So first thing is, it's very, very difficult to know what's actually spent and to be able to compare. But then the question is, if you have the money, how should you actually allocate it? Because the approach we take to allocation might make a big difference to how much can you respond to outbreaks or to new health challenges. So traditionally, what we see is a lot of public health and preventive programs are organized in a very targeted way, what we might call vertical programming. It could be focused on diseases like tuberculosis and malaria, or on risk factors such as tobacco. Now, the advantage of this, of course, is you've got a clarity of purpose. You can set targets to achieve. But the downside is it becomes inflexible. It's a system for bureaucratic and political accountability. And of course, in the lower and middle income countries, this is quite often how the donors are financing, because it helps them with accounting and getting an outcome. But it often means that it's not necessarily tackling the priority issues that require attention from a prevention viewpoint. So as countries then graduate from the global health initiatives, and in the Western Pacific region where I've worked, this is, of course, a very important issue as countries move towards middle income level or upper middle income category. So the first thing you might do is to harmonize your program. So while you might still have specific services target to TB or malaria, you try to bring together the work, the shared functions like surveillance, outreach, the lab services, the health education. So that's sort of where we start with a lot of public health programs. But you can also target, of course, different population groups. And here you could specify the services. But exactly what services are included and how it's targeted is usually a matter of politics. And these political decisions may be informed, of course, by the social movements. So whether that is a way to assure prevention is really a matter of the kind of advocacy that goes on. Now, what we do know is if you're going to put money into primary health care rather than institutional care, such as hospitals, you could make the money go a much longer way. it's more cost effective to be focused on primary health care. But here again, we've been talking about this for 45 years. The countries that have had a strong primary healthcare system, like Malaysia, Sri Lanka, Cuba, and in the earlier days, China, you know, there have been very good health achievements, health outcomes. But in many places, primary care is still seen as only frontline. So it's individual clinical care. It's about when people front up to a clinic rather than the outreach and the prevention. So I think it's better to put more money into primary care, but you still need to be specifying. And in China, under the current reforms, what they have done is to specify what is an essential preventive health services package that the government will be funding, and that the funding can be tied to whether the targets are reached or not. So that's one way to incentivize and move things further. Many countries for a long time have also looked at a place-based approach where they say, here's your population, let's give you, you know, an amount of money for each person. So it's a capitation system, go to it. In theory, if you had limited amount of money for a group, in theory, you would want to put more into prevention because it's more cost effective. You want more services to be based in the community. The reality of many capitated systems, however, is that the doctors and the specialists and the hospitals hold more power. So when there's competition for constrained resources, or when resources are capped back, it's often those who are more powerful whose voices will dominate. So that's the health sector. So what else could you do to improve prevention? Well, we do know that social determinants of health are very important. So what can you do to perhaps encourage action from other sectors, whether that's housing or agriculture, environment, transportation? There are many areas where in South Australia, under Health in All Policies, they did argue that health sector expenditure keeps going up. And so by funding some other sectors, it's a way of actually managing the healthcare costs as well as improving people's health. But here, what you need is a good policy and budget process, as well as very well targeted policies in other sectors, which can really go to the prevention issue rather than just for perhaps the usual call on the money. Now, finally, we're seeing some quite interesting developments globally. We're seeing well-being budgets like New Zealand and Australia moving in that direction. We've had these health and all policies in Finland for 40 years, and now people are talking about health equity in all policies. And we do have in Bhutan gross national happiness rather than gross national product in the economic sense. So with this new evolving global discourse on economy of well-being, perhaps that's something we should be paying more attention to in terms of how do we see the prevention agenda in that. So if you've got the money, of course, one of the challenges is in many countries, the uncapped part is the clinical treatment, and that's the insurance. You see a doctor, insurance pays, whether that's a national insurance or social health insurance, whereas the prevention part is often capped. And when there's cost containment pressures or fiscal pressures, it's very easy to cut the preventive services. So the solution quite often is try to ring fence prevention and to figure out how to move towards a blended payment system in the uncapped part of the budget. Now, Then countries put in health technology assessment systems, and we obviously want to get good value and make the money go further. But cost effectiveness analysis, which is at the core of it, is often comparing two drugs to treat, rather than say, using this drug versus actually using a prevention campaign on the risk factors. So we don't often deal with allocative efficiency, and sometimes we don't actually, it might be cost effective, but we might not be able to afford it in the budget, again, particularly in low resource environments. So it's important, but we still have to really work hard to get to that prevention angle. And then we can think about some other approaches to perhaps improving what we get out of the money, using evidence-based guidelines, which we have a lot in the clinical side, less so in preventive services, although there has been, a growing amount of that. And the activity-based financing and results-based financing, which have become very popular, especially with many donors, it's still much easier for those individual clinical services rather than the population-based. So these continue to be some of the challenges that need to be navigated. So then I think we confront some choices. When we think about national budgets, when budgets cover both public health and finance in clinical care, then of course, public health is going to be squeezed. So then is it better to have a social health insurance system? Not necessarily, because then people forget about that the public health bit. But a country like Switzerland does levy social health insurance to create a health promotion foundation, thus creating more funding for prevention and for very targeted programs. And while we have a framework convention on tobacco control that countries do have to increase their tobacco taxes, then it's an opportunity to again think about health promotion foundations as we have in a range of different countries, as well as having a price signal to try and decrease.
Then we seem to have lost you. Are you there? Vivian's there, and you just had a few more minutes to go, Vivian. So we will, before I introduce Michael, we'll come back to you if you would like to just share that last slide of your screen.
I don't know why my computer has died, so I'm on my iPad.
Okay.
So my last comment, which is what was on the last slide, is really, I think, three big questions that need to be answered. And I think our other panelists could help move some of this conversation forward with them, which is, how do we actually create value and maximize value? By this, I mean the best health outcome possible through financing measures. Second is, who should be part of the decision-making process? Surely it's not only Treasury. But how broad do we go to a participatory budgeting approach? And where's the constituency for prevention? And my last question is, how do we transform actually the way we deliver services and programs so that they are as efficient, as accessible and effective as possible? Because for the limited amount of money, we really want to maximize what we could get out. So I'll leave those as the big questions. Thank you.
Thanks, Vivian. Those are really are the big questions. And it is actually a very good segue into the presentation by Professor Michael Baker. He's a public health physician. He's a professor in the Department of Public Health at the University of Otago in Wellington, New Zealand. There's a wide range of public health research interests with a focus on infectious diseases, environmental health, and improving housing conditions. His work during the 2020-22 was dominated by assisting the COVID-19 pandemic response He's a member of the Ministry of Health's COVID-19 Technical Advisory Group and a leading architect and advocate for COVID-19 elimination strategy. And for those of us who live in this part of the world, he became very, very well known through those processes. He established a program of research on the epidemiology, prevention and control of COVID-19 in New Zealand, and it has generated a large amount of published research and commentary aimed at improving the pandemic response and preparedness. And that's really one of the questions in a different wording that Vivian put to us.
Okay,
Michael.
Kia ora koutou from New Zealand, and it's great to be joining you. And thank you, Michael, for the introduction. I'll just share my slides. And I think I'm grateful to Vivian, who has set the scene so well. When Michael talked to me about this, I said, well, I'm not really a health systems researcher, but of course you realize that the pandemic, for example, is very much a health systems issue. And so I'm going to really talk about this theme of greater health security, which I think is a priority for resilient health systems. And we've seen what happens when these systems are under huge stress, as they were during the pandemic. And I'd like to think that we can learn from this experience and, as the cliche goes, build back better. So that's, I guess, the opportunity. So I'm going to talk briefly about health security, what we can learn from COVID-19, these huge system impacts, the fact that preparedness saves lives, and also a very well-designed, rapid public health response also saves lives. And also we get these multiple, I think, co-benefits from having effective health security built into the system. So health security, it's a funny term. It means, as far as I can tell, it means completely different things to different people. There are certain definitions, and I'm just defaulting to the WHO online definition. It's these activities that require both proactive and reactive activities to minimize the danger and impact of acute public health events that endanger people's lives across geographic regions and international boundaries. And they do note in their online discussion that really there's quite a wide range of things that can fall in this range, and that includes pandemics, health emergencies, but also weak health systems that cost lives and also pose great risks to the economy and security. So there are some other very interesting comments on this idea. One is really an idea of moving more towards focusing on human security. And this idea has also been around for quite a long time. And that emphasizes more the focus on people rather than states, and emphasizes collective action rather than competition. And I would like to see us do more of this and less perhaps of the more nationalistic or even vaccine nationalism that we saw in the pandemic. And also there's quite a bit of commentary about how health security overlaps really intensely with investing in health systems in general, which does make huge sense. So just to remind you that pandemics have profoundly altered history. They all vary. And I think one of our faults, our failings recently with COVID-19 is to imagine they're all like influenza or some other paradigm. And in fact, they vary in terms of transmissibility, severity, controllability, and also how much we know about them. And so when you're trying to think about what should we be preparing for in the future, what sort of scenarios, you can think about this combination of moving from low to high case fatality and from low to high transmissibility. And you finish up with this quadrant here of all the things that we need to worry about in the future in the pandemic area, obviously influenza, but also smallpox if it was recreated, emerging disease X, that's really the typical spillover events like COVID-19. But I think increasingly there's a concern about novel synthetic bioweapons. So we know, I think we're all very familiar with all of the drivers of emerging pandemics, our intensive livestock rearing, humans moving or intruding into wilderness areas, these gain-of-function experiments and the potential use of AI, and really, unfortunately, deteriorating international relations and really bringing up potential problems with bioweapons and also biolab security. So some people make a whole academic discipline about trying to forecast the risk of these catastrophic events. And one of my colleagues has really looked at the range of estimates of a natural pathogen catastrophe or an engineered bioengineered one. And this is the risk that it might kill 10% of the population at some time this century. And so generally they're putting that risk at over 1% or in that range. So this is certainly the kind of catastrophic risk we do need to consider. So there's a huge amount of effort going into documenting lessons from COVID-19. I think we're probably almost over this now, but some of us have contributed to several of these processes of trying to define some of the key lessons. And it's just remarkable how catastrophic this, as we know, this pandemic's been. I think the current estimates are 25 million dead, possibly heading towards 30 million dead if you really consider excess mortality calculations, and a number of different authors have done estimates. But I also think the long-term effects, long COVID, is looking like it may be the largest single health impact from the pandemic. Even the low-end estimates, and WHO estimates may be a bit high, but there are often additional evidence coming out about unexpected long-term effects. So I think we're just very uncertain about this. And if you're looking at burden of disease calculations, they're always a combination of years of life lost through premature death, but also for living with disability. So that's why it'll be some time before we can really look at the human cost and the economic cost of the pandemic. So the economic cost has been truly enormous, and we see this estimate recently of 14 trillion lost GDP to the US economy alone. And so obviously it's hugely larger than this for the global economy. So I think the good news is that preparedness saves lives. And this is a study that came out recently, and this is looking at countries. It's got 195 countries on this regression plot. And this is looking at their Global Health Security Index and their cumulative excess mortality. And this is showing what you'd really hope to see for a tool like this, that if you had a higher level of global health security on the scale, you had a lower cumulative excess mortality. So I think that's a really positive finding. It says preparedness saves lives. And so you won't be able to see this, but this is showing that that index actually has 6 component parts. And I think it's really interesting that the most protective effect comes from this 6th index here, which is looking at the risk environment. And this includes government effectiveness, public trust in government, level of inequity, and social exclusion. So I think this is really reinforcing the huge value of the public health associations of the world and your organized efforts, because we're really focused on these areas, and it's showing that it's hugely protective for death during pandemics. So that was the preparedness side. The other area for health system investment, of course, is having a very rapid, strong responses. And in the past, we had baked into our pandemic planning what I call a very weak response, which is that, yes, you control it, but you go to mitigation, which is just minimal controls, or as much as you can manage to reduce or avoid overwhelming the health system. Or you might move up a bit to suppression. But this was a revolutionary idea for pandemics, and that was elimination. Initially in Wuhan, the Chinese showed they could do it, and then other countries in our Asia-Pacific region did the same. And there's nothing exotic about elimination. We're doing it for lots of diseases. It's just it hadn't been done for pandemic diseases before, not in the same way. So New Zealand, and just like Australia, we launched into an elimination strategy, not absolutely sure that it would work. It did look, I thought, very plausible, and it was certainly something that we wrote about and advocated for. So if we jump ahead 3.5 years, what happened? Does the evidence support this strong response? And yes, it does. I mean, the countries that pursued elimination kept their excess mortality very low, particularly during that elimination period. Interestingly, New Zealand, because it really kept a whole lot of viruses out, is only now getting back to zero excess mortality after 3.5 years. But again, other countries, Taiwan, Singapore, Australia, also in this low range compared with countries that pursued suppression. So one of the things about taking this strong response, it also protected human rights and it gave people much more freedom. And this is showing the level of stringency of controls in New Zealand compared with places like Sweden, which celebrated their supposedly high level of freedom, the UK and the US. And if you look at days spent with low stringency, New Zealand sustained that really through these 2 years, much lower than Sweden and other countries pursuing suppression. And we all joined really the rest of the world after we were highly vaccinated in 2022. So this is showing also that countries pursuing elimination also did very well economically. So really, I think it's a very strong argument, evidence-based argument for these strong proactive responses. And so obviously, we want to enshrine these ideas at a global level. And we have the organizations like the Independent Panel for Pandemic Preparedness who are advocating for really a health systems response at a global level. Equity of vaccine production and distribution, preventing future outbreaks, and strengthening organizations like the WHO, who we really need to be in a highly functional state. One of our concepts we put forward is really around the international legal environment, the international health regulations, and we think they should be strengthened. They're being reviewed at the moment, and that when WHO assigns this categorization of a public health emergency of international concern, they should also make elimination the default response to that point. So elimination at source, or alternatively, delaying spread to allow vaccine development and other control measures. And remember, with influenza, we already know the world can produce vaccine within 3 months to deal with a new pandemic strain. So that is not such a long waiting time to have these kind of measures if you knew you'd be able to reduce your case fatality risks down to a lower level. So just to remind you, of course, when you actually look broadly at the kind of risks we need to prepare for, it's interesting, we in health think a lot about pandemics, but if you have an organization like the World Economic Forum who do this global risks survey every year, and this is a very long list of quite scary things, 32 things on the list. Infections are way down here. The things they identify are these environmental disasters that we're confronted with, a failure to mitigate climate change, to adapt, natural disasters, biodiversity loss, and even large-scale involuntary migration, which may well be driven by climate refugees. So this is just giving us a taste of the kind of range of hazards that need to be managed with a very solid global health security agenda. So this is just looking at other categories of threats. These are, and this is honing down on New Zealand. Just we've had, like Australia, a lot of severe weather, extreme weather events and cyclones, and just how they are adding to the total of human misery. And these are mass fatality events over a century or more than a century, just looking at the range of hazards, some of which are very hard to prevent, but ultimately all of them have a preventable component. So I think anyone who works in public health for very long starts to wonder, well, why are we not always making the right decisions all the time? And you start to look upstream to the kind of decision-making institutions we've got. And I do find the Sustainable Development Goals do broaden your interest in public health. I think we probably think about all of these now, but I think looking at ones around promoting peaceful and inclusive societies and building effective, accountable and inclusive institutions, this is often what drives what happens in terms of things like preparedness and investment in sustainable health systems. So, of course, the time to invest is now. You don't wait till you're on the brink of your next pandemic or your next crisis. When you're coming out of a crisis, is a time to use this knowledge and hopefully momentum. The big problem is that I find is that we're very good at forgetting, and I think it almost feels like deliberate forgetting. We want to put the pandemic in the rearview mirror, and we can't forget it. We shouldn't forget it. And this is what we did on the anniversary of the 1918 flu pandemic. And this was going to my son's school and getting 440 of the boys to lay out in the paddock, which was quite difficult. And the photographer sent up the drone. And this was trying to get a picture of what it looks like if a pandemic hits, how many people would die in a day. The media were completely disinterested in this. And I do think it's a little ironic because, of course, a year later, COVID-19 was starting to spread, but hadn't been seen at that point. So hopefully I've been able to contribute to this theme of investing in sustainable health systems or health services. And I think we need to look at public health measures such as pandemic preparedness and rapid response capacity, resilience to a wide range of hazards, and ultimately addressing the wider sustainable development goals to try and reduce these drivers of major global hazards like climate change and armed conflict. And ideally, health security infrastructure can also support improved public health and healthcare during low threat periods as well, because this infrastructure should be very versatile. And just acknowledging my many colleagues who I've been working with on these sort of ideas for a number of years. Thank you.
Thank you so much, Michael. And that was a fantastic building on what Vivian had said, introducing sustainable development goals and how important they are. And my language is introducing the public health paradox. Seems that the more successful we are, the more people forget how important prevention and public health are. And it's a paradox that we might discuss a little later. But thank you very much for those insights. It's now my great pleasure to introduce Eduardo Pisani, who is the CEO of Allcan International, a global multi-stakeholder non-profit organisation focused on improving cancer care efficiency. Currently, he's also engaged in the digital health field as a senior advisor to Tech Care for All, a startup with a social impact mission which is active in low and middle income countries, particularly in Africa and India. Eduardo has contributed to advancing public health policy discussions from a close vantage point, having over 3 decades of international experience in senior roles for global healthcare companies and associates. He's contributed to developing and implementing policy research projects, as well as partnerships with international and non-profit organisations, ranging from digital health to non-communicable disease, neglected tropical disease, to medicines counterfeiting. It adds a whole new element. Having Eduardo here adds a whole additional element to our webinar. I'm very pleased to introduce him. Eduardo.
Thank you very, very much indeed, Michael. Thank you for having me today. Good afternoon, good morning, good evening to all the participants. And I will definitely try to build on the presentations of the previous speakers. And I will try actually to perhaps look at these issues from a slightly different perspective, a slightly different angle, notwithstanding, obviously, the key question which we have in front of us, how to ensure that health systems can increasingly become sustainable, efficient, and that's actually one of the words that I would like to use. Is it a distant dream? Allow me to start from this, because as I was preparing for this discussion, I realized that actually, even in the course of this year, 2023, there have been numerous high-level discussions that have got to do with health financing. And just for the sake of the background, if you will, of the context of my considerations, I wanted to submit to your attention some references which have got to do with inspirational approaches, in my opinion, which make me somewhat optimistic in answering the question, is it a distant dream or not? The well-being economy has been already referred to by Vivian, and definitely this is a concept which covers inclusive growth, health equity at the heart of public, social, and business endeavors. This is really a sort of manifesto which I also take on personally in my own activities. It's clear that narrowing the health gap is not only a matter of social justice, but it is essential to build the trust, social cohesion, and economic resilience. I'm reading these quotes for the simple reason that I would like to demonstrate that the subject matter that we are addressing today has been, is, and should continue to remain very high on the radar of governments and civil society organizations and all stakeholders, actually. So the other concepts which have been expressed lately after the pandemic by the so-called Monti Commission essentially underscore the fact that there is no sustainable path forward without governments prioritizing health in their spending. This is something which has been demonstrated clearly by Michael a few minutes ago. My additional focus, which I will expand on in this conversation, is that we need also more efficient and equitable spending. And therefore, the question that Vivian was asking at the end of her considerations, how do we create value? That's really where I would like to get to. Finally, it's important also to bear in mind that this endeavor, this task, is something which clearly is on the government's duties and obligations, let alone budgets, but it is something which has to be inclusive and has to also attract the contribution of the private sector as well as of other non-governmental organizations. Now, a reference has been made also to the SDGs. Here I'm focusing and I'm thinking about SDG 3, which is the one, as you know, that focuses on health. And one thing that is fundamental to underscore in order to try and find solutions to the question we are addressing today, one element is that sustainability and health system performance are closely connected. And therefore, improving efficiency of a health systems organization, financing and delivery modalities would maximize value for money, minimize waste, and help future-proof the system to meet growing demands. These are actually aspects and considerations that have been elaborated over the past several years and are published. So again, I'm here quoting some of the outstanding work which has been carried out to date, but also concepts and directions, paths of work, which I think we should continue to build upon as practitioners. One other element of information has got to do with the so-called accelerator that has been put in place by several organizations, public organizations, in the context of the implementation of SDG 3. Now, I use the expression implementation for the sake of explaining that there is significant work ongoing. You will see on this map, particularly on the right-hand screen at the top, the fact that there has been an analysis on how to ensure that there is more money for health, more health for money, how to facilitate consensus building and knowledge sharing and innovative funding. All these elements are being assessed and further elaborated really as we speak. Now, efficiency. Efficiency is a concept which is clearly connected, as we said, to value. It is also connected to better health outcomes. And I disclose the fact that efficiency in cancer care is really the focus, and it is the core of the work of Allcan International, the organization that I represent. And this focus on inefficiency in cancer care in particular, which I would like to offer as a sort of case study to everybody, started from the assessment that was made both by the OECD and the WHO in recent years, whereby, according to the OECD, 20% of all health expenditure is wasted on ineffective or inefficient practices. And this would correspond to 2 years of life expectancy. Now, the WHO, with a broader global remit, looked at similar parameters and came up to the conclusion that in other regions of the world, waste in healthcare spending can reach 40% of the total health expenditure. So here we are talking about a critical element in a strategy towards sustainable funding for health. The other dimension which I alluded to, and which implies that beyond the government contribution and the government commitment to public health strategies and public health investments, there is also a growing public-private partnership model, which is also supporting or enabling even sustainable funding models. Here I have got a few examples. Allow me to start, just for the sake of, again, of the context, from a very recent statement. It's the private sector constituency statement, which was released a few months ago in light of UHC 2030 and the ongoing discussions regarding the achievement of SDG 3 again. And I think it is important to recognize that the private sector will and should integrate UHC principles into business, will continue to deliver innovations that should respond to the needs of all people, make these safe, affordable, accessible, and sustainable. And again, here I'm quoting, help strengthening the workforce, and moreover, here, to the point of our discussion today, contribute to the efforts to raise the finance available for UHC. Now, clearly, many would ask, okay, what does it mean from a practical perspective? From a practical perspective, there are myriads of examples, thankfully. I will mention 2 or 3, and then I will dig one level down and come to my conclusions. Examples are somewhat illustrated, on the right-hand side of this slide. Let me start with one initiative which is very dear to my heart, and it's called the City Cancer Challenge, better known as CCAN, which has got to do with improving cancer care, and it is a public-private partnership to the extent that through the facilitation of the CCAN Foundation, cities, local administrations, and other partners of different nature, whether it's the World Bank, whether it's the private sector, etc., they get together in order to define an action plan that is aimed at improving cancer control and cancer care in given parts of the world. Similar to this, and it's even a broader set of examples, there is an initiative known as Access Accelerated. All of these obviously is easily available on the internet. And Access Accelerated has its own focus, specific focus on sustainable funding for health programs. And within that category of activities, there are very telling and very impactful case studies and stories which you may want to refer to. Let me move on and draw to the conclusion of this talk. I was referring to cancer care in particular. I'm still using the efficiency, the value concept, well, value connected to efficiency, connected to better outcomes, as a concept that connects us with sustainable health systems and sustainable health funding. One thing which seems clear is that our health systems around the world will have to invest on data analytics capturing in order to become data-driven learning systems. This is also an expression which I really bring to your attention because it is part of the sustainability and of the efficient investments that could and should be made actually in all geographies, in all regions of the world, in my opinion. What gets measured gets done. And measuring interventions and the value of both policies as well as specific interventions, as I was saying, in any area, let's take as an example cancer care, would allow to consistently benchmark and improve efficiency, therefore achieving more value for the money invested. One of the recent projects, research projects that we have conducted, one has been already published with the University of Southampton in the UK. The next one will come up hopefully by the end of the year with the University of Amsterdam Medical School, has got to do with metrics, with efficiency metrics. And sorry, here is an example of what I mean by that. Efficiency metrics would de facto imply that there are certain parameters of reference that are applicable anywhere, can be measured routinely, and can translate across cancer types in this case. Examples are listed here: time to diagnosis, primary care interval, patient experience, etc., etc. These 8 core metrics listed here were identified by or through the research as really being applicable and existing everywhere. And I will not dwell into the details, happy to discuss this further. Last but not least, implementing efficiency programs can be done in multiple ways in any part of the world. And really here, I have extrapolated the most recent highlights in 2023, which have got to do with cancer care navigation in Australia, how to reduce diagnostic delays in different countries, and how, to Vivian's point, enhance screening and early detection and enhance, frankly, prevention overall, which is part of the discussion and the work program that we undertake in different countries. So I'll spare these list of concrete examples, and I'm really done. These are all practical ways of improving efficiency and therefore reducing waste, and therefore reduce or contributing to the sustainability of health systems. What we need, and this is really my close, Michael, what we really need is effective political leadership together with collaborative input, insight from civil society organizations and the private sector. Thank you very much. I pause here.
What an interesting way to finish, because in one of her key questions, Vivian asked us, so who are part of the decision-making? And it was her second key question. And Michael touched on it, and then you have concluded in terms of the political side of the decision maker that drives these things. And 2 or 3 of our questioners have touched on this issue. So I'm going to ask each of you, actually starting with you, Michael, how important is political leadership in your experience in dealing with what we're trying to achieve: more efficient systems, better prevention, and all the things we've been discussing? Starting with you, Michael.
Yeah, well, you've got 2 very different contexts for this. And when a pandemic is coming, and I think it does really sharpen the attention of our political leaders like nothing else I've seen. So that's a somewhat unusual situation. And then you get not just the health sector, but the all of government response. And in many ways, governments around the world, I think, were completely preoccupied by responding. And then at that point, you obviously have a huge amount of political attention and also obviously a lot of officials working on the problem. But what happens next varied hugely around the globe. And I think it's fascinating that, you know, with the same evidence base, the same knowledge, governments did such different things. And I also thought that in my experience, there's usually a lot more, I would say, international collaboration to shape more common agendas, certainly at least amongst high-income countries that have got a lot more resources. But I felt actually countries seem to be doing very much their own thing in quite unexpected ways. And there was obviously some direct government-to-government communication, but some of these regional networks and certainly the global networks that the WHO ran didn't seem to be functioning terribly well. And it just, in a way, it showed to me how fragile a lot of that international collaboration is. It worked very well in some scientific disciplines like sharing genetic material, but a lot of those initiatives were not really tied to particular governments. So that's an unusual situation for, I think, the health system when it became such a major focus, and I think broader, the all-of-government system. In between times, I think health care in general goes through periods of moderate attention and quite long periods of neglect by political leaders. And sometimes it's quite good if they don't change things too much or try and change things. But in general, you want them to be focused on health goals, I think, and really prioritizing them. I think it's also interesting to see where health ministers are ranked in governments around the world. And generally, it's not a top portfolio, which I think often reflects how governments prioritize things. So yeah, that's a couple of points really about that.
And Vivian, you looked at the right across the Western Pacific there, so countries that of high income, low income, etc. Political leadership. Anything else you want to add in terms of in that context?
Yeah, look, it's a really, really important issue. And I must say that at times I get very frustrated when you look at WHO publications, and for every single program it says there must be political will. I think the question is, where does political will come from? Because political will doesn't drop from the sky. It isn't one person who happens to be a health minister who just loves and is truly dedicated to something. That may happen. But, you know, it's the ecosystem of politics. And so you've got many different issues competing for attention. There are things that needed to be trade-off. So you need a constituency and you need to have multiple voices. So, you know, going to what Eduardo was saying at the end, you know, if you've got the private sector, you've got civil society, you've got leadership, all in support of something, it makes it so much easier to get political will and to deliver on the goods. And I think this is why it's really important to also think about long-term public health policy should be bipartisan. And parliamentarians really need to, you know, be included and educated, because at least in most democratic countries, each side of politics could be in government. And the parliamentarians are in touch with their constituents and need to reflect those views. So that's what I think we must think about public health as a social enterprise, and therefore building political will is part of what we need to do.
Just before I go to Eduardo, I will just add a small thing, as having been a health minister over 20 years ago, one of the things that I thought was really, really important, though, and having watched therefore other, I'd say other successful health ministers, other ministers and those who are successful, is having power in the cabinet is really, really important. And that goes to, as Michael said, where does the health minister sit? And it's not just sitting within a government sense below Treasury, below Defence, whatever, but it's more than that. It's also within party powers. And so it's an interesting concept that we need to take into account with our advocacy work. Eduardo, did you have a comment to make on this?
Let me start by saying that I am in violent agreement with what Vivian and Michael have just said, because especially in today's politics, the bottom-up approach is much more successful, or at least can get on the radar screen of policymakers much faster than in previous decades, where perhaps it was more top-down and ideally there was a sort of strategic vision for the future. Now it's COVID, and therefore, what do we do about it? And a practical example that I submit for your consideration, and I'm sure you're aware of, is the so-called Next Generation EU program, which corresponds to Build Back Better in the US. These are billions and billions of euros which have been injected, and unexpectedly and in an unprecedented manner, there is a segment, a portion of few billions, which has been allocated to public health, and it's known as EU for Health program. This never happened in decades of existence of the European Union, and it was COVID which actually triggered it. Now, the question is, after the launch of the framework program, a number of important actions which are in implementation phase, will the momentum continue, and will the governments of, in our case, 27 member states, keep building and investing on the opportunity to build back better also healthcare systems? I don't have a definite answer, especially because, as everyone has anticipated, there are competing priorities, unfortunately. One thing, however, that I would add to the discussion is the One Health strategy. The One Health strategy, which, again, is sort of underpinning a number of policy decisions, even legislative decisions, and which is putting together various stakeholders that previously would not talk to one another: transport ministers, energy ministers, and health ministers. This is happening now, thankfully. And again, the couple of examples which I was quoting earlier, one is the French ministerial initiative that took place in June about new financing models, includes a section on health, and it's not only health ministers who are invited. So that speaks to the evolution, hopefully, of the debate that we are addressing today. Thank you.
Sort of leads into the question from Leland Wagoa in our Q&A area, who's asking, well, what about low and middle income countries, and how come WHO, or how do they plan to influence political will? Vivian, I'm going to go to you because you work with the WHO, but I will just preface it by saying one of the big impacts on my attitude to WHO was learning that there's a single German teaching hospital that has a budget that's bigger than the WHO. And, so curative medicine, as you talked about. And of course, the WHO is made up of the World Health Assembly participants, the countries. And so that's actually where the political power is. So giving that as a background, however, WHO can have influence. So do you have something to add there in response to that question, Vivian?
I think, Michael, what you mentioned are really very important structural constraints, and it is important to understand that WHO is part of it's a technical agency under the United Nations. Now, the big plus of WHO is it's very much trusted by countries. So quite often you have access to privileged information, access to senior people. The flip side of that, of course, is people want the WHO to be out there, in neon lights, condemning governments. And if you do that, you'll never have the access again. So it's a very delicate balance in terms of the kind of political advocacy that WHO can do. I've certainly seen where the WHO is engaged in policy dialogue, not only with the health minister, but with the deputy prime minister, with the minister of finance. I mean, I've been personally involved in these instances with the speaker of the house, etc. And so the WHO does have access, but it works via diplomacy and obviously an evidence-based approach. So there are limits.
Yeah. And Michael, if you can respond, but also look at that last comment we've had from Robert Kogi, saying, so should we encourage public health professionals to be political, be active in politics?
Yes, well, I think I'm hoping that most public health professionals are active in politics with a small p, the policy aspect, policy development. And I think if you've got a solid evidence base, then that seems very reasonable. But also I think the other part that goes with it is a very strong values base. So we don't just, and often it manifests in the issues you choose to take on, because there's always a huge range of issues, but issues where you can see an opportunity to make a difference. And I think I'm very pleased that health equity is now acknowledged as a major driver. I think that's, I mean, it's been there for a long time. And I think I'm a huge fan of the World Health Organization. I've just spent a week in Manila working on measles and rubella elimination approaches, and I think they're fantastic where they work. I just think they haven't got enough resources and often enough mandate, I think, to achieve, I think, the vision. But the other thing, of course, is that they have a very minimal profile in high-income countries because that's not their priority a lot of the time in terms of their scarce resources. But I think they do have a wonderful role in standard setting, establishing norms of practice in a lot of key areas and producing reference documents if they're given the opportunity and the resources. So I think that's a really important role. I may have rambled away from your question there, Michael.
No, you're all right. We're just covering these things. And I'll let Eduardo, I'm quite capable of bringing you back into the point if I need to. But Eduardo, did you want to make a comment on this one?
Very briefly, and without going too far in the past, I think it was Plato who said that democracy is participation. So I can only invite anyone from any professional category, including health, in particular, healthcare professionals, to have their voice heard. Now, again, what's happening in these days in many European countries, and I will use the region that I'm more familiar with, but I suspect that it is applicable also to other parts of the world, because of cuts to healthcare budgets, physicians, nurses, other healthcare professionals are either being reduced numerically, so there is less of them to meet the same expectations as before, or their salaries are so stagnant that actually they cannot compete with other private sector jobs, to put it simply. And they're all marching in the streets. They're all being vocal about the importance of defending, protecting a national health service, of protecting the system which is truly universal and which doesn't, especially in our cultures at least, doesn't get privatized or driven exclusively by profits. So this is really happening. A final word, if I may, again, to relaunch on the key role of WHO. Now, the good news is that I think that other organizations such as Gavi or the Global Fund and the World Bank Group, they are also part of this discourse and are part of these negotiations. And I trust that the combination of their energies, knowledge, and commitment can really bring the issues up on the agenda of all governments. Thank you.
And Eduardo, before I go to you again on the question from Erica Whitgrow, which is about vested interests, how do we manage that? Let me also say that when I'm teaching public health advocacy, which I do regularly, I think my second or third slide goes, public health is political. and I'm using the way that Michael uses it as well, like small p, political, but we need to use what we can to influence decision makers, and as Michael points out, on our values base, and that's when we can be successful. But back to you, Eduardo, about vested interest, those who are currently benefiting, and I think it's implied, meaning to the disadvantage of the population health outcomes.
Right. Yeah, this is an ongoing discussion, especially if it refers to some specific categories of the private sector. Let's look at it broadly. When it comes to public health, there are I don't know, food companies, beverage companies, the pharmaceutical industry or healthcare industry at large, etc. Well, there are several things that have evolved over the past several years, I would submit. Number one, transparency of declaration of interests. This is what we do, and this is what we propose to do together in partnership with other organizations, whether it's international organizations or governments. There is a second element. There is a constant vetting or presence of civil society organizations which have an independent perspective, an independent position, and allows really to understand where the differences between the public interests, the common interests are, and where it becomes exclusively a vested interest. The initial statement I quote, I do not represent here the private sector, but that said, the fact that there is a for-profit industry that participates also in or shares common objectives for global health and public health specifically is something which has been repeated many times. Clearly, I cannot comment, I do not want to comment on bilateral contractual negotiations which have existed lately and which have raised some eyebrows because we don't know what we don't know.
And we don't have time. In fact, and time is, as always, at our back. And so I'm going to just give you each a chance to have a final take-home message for us. So what would be your final take-home message, starting with you, Vivian, and then to Michael, then to Eduardo, and then I'll have a final comment.
I think my message is to become friends with people in the Ministry of Finance. Firstly, you learn a lot about how governments really work when you understand financing. Secondly, sometimes it's the finance people who are really interested in prevention, because in so much of the health sector, there is so much money in hospitals and drugs and technologies. That's where the vested interest is. And so it's the finance people who can actually be interested in creating more value.
What an interesting comment. Thank you, Michael.
Yeah, I would just add to what Vivian said, and Eduardo as well, that I think we absolutely have to stick to our guns. If you believe that evidence is on your side and the principles are there about improving health and equity, just go for it. Don't hold back. And remember that almost everything you do in prevention is highly cost effective. It doesn't usually even need an economic analysis, partly because healthcare is so expensive. Disability and premature death is so expensive, not just economically, but I mean and socially and in every way. And so we have that saying, I think Michael might have referred to it, it's almost a curse of prevention. Or in the pandemic world, we say a public health triumph, nothing happened. And it's the difficulty, it's why you actually have to use modeling and anticipatory policy making to predict what's over the horizon. And then I don't think hold back, don't feel shy about that you're not coming from necessarily a highly specialized elitist branch of the health system. Stick with your public health principles. I think that history will be on your side if you do that.
Eduardo.
Thank you. I would use my 30 seconds to restate that measuring is important. The fact of ensuring that the sustainability of health funding is not exclusively related to government injections, but also to how the available money is managed. Therefore, I repeat my plea that it's important to improve efficiency, and it's important in healthcare, and it's important to get the value for the money which is invested. Efficiency is not only about reducing unnecessary wastage of resources or avoiding the duplication of labor. It's also about improving the outcomes and the experience of people with certain diseases which have to, which have to access healthcare services.
So thank you so much. It's been fabulous listening to you and getting an understanding of where we're at. The World Federation of Public Health Associations represents about 5 million public health professionals around the world, over 100 membership organisations, and we're very keen to keep this debate going, that where we're not just talking about disease and absence of disease, but broadening the whole discussion. And tonight, you three have really done that very well. A thought comes into my mind about doctors saving lives and firemen saving lives. And then I quote from Johns Hopkins, public health professionals save lives, except we do it a million at a time. And and when we can put aside that public health paradox and remember that, then it's a really important thing. I do need to add that tonight we were supported by the University of Geneva, and thanks along with Pfizer, MSD, and GSK. So we appreciate that support for our webinars, and I meant to make that declaration at the start, and I apologise for those who when I hadn't mentioned that. So it's been a really fabulous evening, and I think the lessons we've learned from tonight are incredibly important. And for me, the final lesson is, yes, public health is political, small p, and we could all play a role in influencing. And one way to do it is through your own public health association. Thank you, everybody. Really appreciate it. And a particular thanks to those who were here on Zoom asking questions and participating, but also to those who are following on Facebook and through other means. It's been really appreciated, and I hope it's been useful for you as well. Thanks, everybody, and good night.